Hey everyone, welcome back. For those of you who are interested in having a one-on-one conversation with me, where we can go over your Oscar data, your sleep study, or just your overall sleep disorder breathing profile, try to find some answers, I've left a link in the description box below, where I will also put Dr. Rama's contact information and website details. Good luck everyone, and I hope that you guys find some answers in this video.
I am Anil Rama, MD. Bit of my background, I am a neurologist and sleep medicine specialist. Been doing this for 20 plus years now. And I set up and ran a huge HMO's sleep medicine program and been faculty, at least adjunct faculty at Stanford for, 15 plus years. And yeah, and so I myself have gone through the whole sleep process of expansion, advancement, nasal surgeries. So I am very well familiar with the pitfalls and the successes and the emotions and everything that goes with, the process. But into my career, I realized that even though you can go through this entire 2-year journey of fixing your sleep and doing all the various surgeries and whatnot and medical treatments, sometimes you're left with some residual symptoms that don't seem to get better. And it's rare that someone is 100% better after they treat their sleep and breathing issues. And so that led me down the line to the brain. And in a nutshell, today's talk is going to be about some of the data I'm collecting on how we can measure brain function and how it's impacted by some of the things that I'm observing. So today, let's just get going. And then at the end, I'll go through the chat and I'll answer all the questions. And I hope, and if everyone is welcome to chime in, can everyone speak if they need to?
Yes.
Okay, perfect. Let's go to the first slide then. So we're going to talk about 4 things today. We're going to talk about the EEG and converting it into a fast Fourier transform. The second thing we're going to show, in my opinion, what an ideal fast Fourier transform for an EEG looks like. The third thing I'm going to show is just some of the examples of a fast Fourier transform, just clinically that I've seen. And the last thing is what happens to the fast Fourier transform with various treatments. There's only 20 slides. It's not a long talk. It's more of an introduction. And there's 2 ways to look at the brain. We could take a picture of it with an MRI or CAT scan, but that's static. It doesn't tell us function. The only ways to do a functional assessment of the brain is with very costly spectroscopy and other imaging, or we can do it with an EEG relatively simply. And so we're going to go over how we can look at the function of a brain with an EEG and specifically the fast Fourier transform. So in a EEG, there's basically 5 basic waves. And I think what you have to recall is that your brain has about 80 billion neurons. And each neuron is firing at a different rate. Some are slow, some are fast, and some are very fast. The ones that are firing slow, at the surface, you collectively measure them as delta waves. And the delta waves represent the neurons in your brain that are firing slow. A delta wave is between usually 0 and 3 hertz approximately. And delta waves are typically seen, at all ages, but you typically associate them with slow wave sleep and especially in kids under the age of 12, they have substantial slow wave sleep. They're making growth hormone. They're growing. They're hard to wake up. And then after the age of 11 or 12, we start to lose a little bit of the slow wave sleep, although we still have it. The neurons that are firing a little bit faster, we record as theta waves at the surface. And theta waves, it could be an ultra relaxed state, but typically theta waves, when you see them when you're awake, manifest more as overtly, they manifest as fatigue and sleepiness. Covertly, theta waves, which are a little bit slower, right, can manifest as, and I use this example, like some people can hear a song once, 10 times, 100 times, but never really hear the lyrics. Or it's like playing a ball sport, football, baseball, tennis, but you don't pay attention to the pattern the ball makes as it comes to you. Or simply that you meet someone and a few seconds later you forget their name. So it's a bit of brain fog, drowsiness, fatigue, lack of presence. And then, and theta waves are typically about 4 to 7 hertz. Then the neurons that are firing a little bit faster are recorded at the surface as alpha waves. And alpha waves are typically about 8 to 12 hertz. Alpha waves are seen, they're present all the time, but when you close your eyes, they are no longer suppressed. And so essentially alpha waves are seen in quiet alertness, as if you're meditating. You're not thinking about anything. You could be gardening, you could be painting, you could be lying on a hammock and just relaxing. It's a calm, awake alertness, and which you're not giving much thought. And then the neurons that are firing a little bit faster than that are the beta waves, which are usually, 13 to 40 hertz or so. And then the ones beyond that, which is not on this graph, are gamma waves, and they go up to about 100 hertz or so. But the beta and gamma waves, they're obviously the neurons that are firing the fastest. On the positive side, they can be linked to problem solving, concentration, intense focus. But on the negative side, they can manifest as anxiety. And that's the point that I think you should take away. Delta waves, all these waves at a certain time, they're helpful, but at other times, they may not be ideal. For instance, delta waves, they're excellent if you're in slow wave sleep. That's exactly what you want. But if you're having delta waves while you're awake and listening to this talk, it may not be ideal. So anyway, that's the quick background on the various waves that you see in an EEG. Now this is a standard EEG. Just a little bit of a close-up. And usually you have about 20 or so electrodes on your head. And because you have 80 billion neurons, each electrode is recording from about 4 billion neurons. Now, when you have a standard EEG, each one of those lines represents an electrode on your head, but you're getting all of it mixed in. In other words, all of the different waves are in there. The neurons that are firing slow, the neurons that are firing fast, the neurons firing in the middle, they're all there, and you're just seeing kind of a summary of all of them. Now, usually an EEG is helpful for if you're looking for seizure spikes, because someone because those are so powerful that you can see them beyond the milieu of the overall waves. And they're also helpful if someone is encephalopathic and they have just substantial slow waves. So there's different reasons neurologists use EEG. But in terms of assessing brain function, looking at an EEG for the average person who's not having seizures or who's not encephalopathic, acutely, it's not very helpful. And so what we do is we take this EEG and we run it through a software. And what we do is we create a fast Fourier transform. It's very important that everyone understands this because the whole talk is based on this. And what we do is this. So you have a standard, once again, you have about 20 electrodes on your head. This is an example of one of the electrodes. So what a fast Fourier transform does is it basically demonstrates in those 4 billion neurons under that electrode, each one is firing at a different, there's different neuron populations firing at different rates. What a fast Fourier transform is, it breaks up that generic signal and says, how much delta is in that single wave under that spot? How much theta is in that single electrode under that spot? How much alpha is there? How much beta is there? And I kind of cut off the screen because gamma goes on for quite a bit. So what a fast Fourier transform allows us to do is to not just see the generic signal that emits from any one of the 20 electrodes on your head, it allows us to see categorize the subharmonics that are comprising that signal. And once again, it all has to add up to 100%. So the generic signal that you see on an EEG is comprised of a combination of delta, theta, alpha, beta, and gamma. I hope everyone understands that. So for instance, FP1, you can see that on the left-hand side. FP1 refers to your forehead, 1 refers to the left side. So basically above your left eyebrow or eyelash and eyebrow, that part of the forehead, that is where this is showing. So out of those 4 billion neurons that are firing, you can see what population are firing in the delta, emitting delta waves, and the others are emitting theta, alpha, and beta. So we are going to go onwards now, and I'm going to show, so that's what a fast Fourier transform is. So now we're going to show you what I think is a near ideal fast Fourier transform for an EEG. This is an individual, 40-some-year-old gentleman, and he had 3 EEGs, one in 2019, one in 2020, and one in 2021. I wanted to show you this example of, of someone who's nearly ideal because, number one, it doesn't change that much unless you do something substantially different to yourself, like you've had a stroke or you do, maybe some substantial surgery or something changes substantially. It's pretty durable, your fast Fourier transform EEG, with obviously some minor, maybe a 5, 10, 15% variation from moment to moment. Overall, it's similar. And so I'm going to go through this. It's very important that you understand this. Let's just look at the one in the middle, just to make it easy, right? You see on the very bottom, so you see all the different lines. Every line refers to an electrode on the body. The bottom one, A2, I want you to temporarily disregard. That is the heart. So we had that represents the signal from the heart. Every other designation on the left, on the y-axis, is an electrode on the head. So we're going to start from the bottom and move our way to the top. You should see O1, O2 on the bottom above the heart signal. And there's 4 lobes to the brain. And the first lobe is the occipital lobe. So O1, O2 refers to the 2 electrodes that are recording from the occipital lobe. O1, an EEG designation, odd is left, even is right. So O1 is the electrode that records from the left side of the occipital lobe, and O2 is the one that records from the right side. The occipital lobe, I'm going to simplify it, but basically is responsible for vision. So you can see the pretty colors, that's your occipital lobe. You know, you can drive at night, that's the occipital lobe. Above the occipital lobe is the crown of your head. And the crown of your head are is the designations PZ, P3, P4, P7, and P8. They're right above the occipital lobe. In EEG designation, Z refers to the center. So PZ means it's right in the middle. P3 means it's to the left of it a little bit. P4 means it's to the right of it a little bit. Now P7 is further left. It's the furthest left in the perimeter. And P8 is the furthest electrode on the right in the crown. So basically, if you have a crown over your your head, in the back a bit, right? That's your parietal lobe. And that's your second lobe that's in your brain. And the parietal lobe is responsible for P for perception. And so all the senses essentially have to go through your legs, through your arms, up into your brain, and they go to this parietal lobe, which is above the occipital lobe, for sensory integration and sensory perception. So what does that mean? So for instance, I don't know what your foot is on, but whatever your foot is on, carpet or hardwood, you can tell the difference just by your foot being on it. You can tell if there's a draft in the room. You can tell if you're hot or you're thirsty. All of that is sensory processing, sensory integration in the parietal lobe. And you always hear about people who have sensory processing issues or sensory, integration issues. Well, that's it. The third lobe I want to go over is right above that. You see the T3 and the T4. We're just working our way up. T3 is right over the left ear, and T4 is right over the right ear. That refers to the temporal lobe. The basic things the temporal lobe does is auditory. You can hear what I'm saying. For most people, language is on their left side, and that would be T3. And you can understand what I'm saying because there's 2 parts to language. One part is comprehension, Wernicke's area, and that's in the temporal lobe. And the other part is expression, actually speaking, Brokaw's area, and that's in the frontal lobe. So that's the temporal lobe. And then now everything above T3 on this map is the frontal lobe. Now, don't ask me why, who came up with the designation, but the CZ, C3, C4 represent the frontal lobe, but they represent the primitive part of the frontal lobe. So it's just basically, if you grab your ear and go straight up, it's the part that goes right over your head. Z's right in the middle on top of your head is CZ, and the left is C3, and the right side is C4. And that's your motor strip. I'm not sure if people have ever seen the homunculus, where that kind of like the lips and the arms and the legs are kind of stretched out over the brain. But in any case, the motor strip is the primitive part of the frontal lobe. It lies right in front of the primary sensory area. If you stimulate the left, like the C3 area, your right hand may twitch. If you stimulate the right, the C4 area, your left hand may twitch. So that's your primary motor area, and it's the primitive part of the frontal lobe. The classic part of the frontal lobe is everything above that: FP1, FP2, FZ, 3, 4, 7, 8. FP1, FP2 are the 2 electrodes right on your forehead, right above your left eyebrow and your right eyebrow. And then FZ is the one kind of where your hairline is in the middle, and then 3 on the left, 4 on the right, F7 further left, F8 further right. So if you had a crown on your head that was in the front of your head, that would be it. And what does the frontal lobe do? Well, that's basically it allows you to stay focused, pay attention, kind of like the, the ADD, kind of like the opposite of ADD. It allows you to take measured risks. It allows you to delay gratification. It allows you, if the world is going nuts, screaming at home, stress at work, stock market going down, despite all that anxiety, it allows you to corral it and you can stay strong in that period of time. Anyway, so it's very important that you understand. So basically what you have is from the bottom, O1, O2, to the top, FP1, O2, you can draw a line from the back of your head all the way to the front of your head. Okay, so basically bottom to top is like back to front. I hope that makes sense. Left to right is not time, as I mentioned. Left to right is frequency. So the first hashtag on this one, I am changing, the first hashtag is 4 Hertz. Then the next one is by 2, 6 Hertz, 8 Hertz, 10 Hertz, 12 Hertz, 14 Hertz, and 16 Hertz. I don't know if you can see my arrow or my cursor, but everything within the first hashtag represents, so basically let's look at FP1. Let's look at FP1 in the middle. That represents the activity. As I mentioned, you have 80 billion neurons. Each electrode is overseeing about 4 billion neurons. So that's FP1, the signals that you're seeing represent the totality of 4 billion neurons. And the signal that you're seeing within the first quadrant before the first hashtag, those are the neurons that are firing in the delta range, that are basically delta waves, the neurons that are firing slow. And, as I said, that's what's usually associated with slow wave sleep. The neurons that are firing basically from the first hashtag to the third hashtag, just as a, to make it simple, 4 to 8 or, 3 to 7 is probably more accurate. But that's your theta waves. Those are the neurons that are firing in the theta range. And then the neurons that are firing between the first, second, third hashtag and basically 2.5 hashtags after that, 8 to 13 Hertz, is the ones that are firing in the alpha range. Those are the neurons firing in the alpha range. And then finally, the ones above that are beta, and I cut it off. I didn't want to have hashtags all the way to 100 Hertz. It would just be a little redundant. So basically, why is this, and I, kind of close, no one's perfect. Absolutely no one's perfect. Just like we can't recreate the physical architecture that nature intended, no one has a perfect brain map. But what you're looking for in a brain map, and why I like this one, is balance. Just like when you do surgery, you want balance of the face, both vertically, horizontally, advancement. You want balance in your posture. You want balance in the various aspects of your life, both mentally and physically. You also want balance in your FFT plot. And what you see is basically, if you look at this gentleman, this was an EEG done with your eyes closed. And when your eyes are closed, alpha is no longer suppressed. It's actually allowed to come out. So when you look at a brain map, the first thing I do is I look at the very bottom. I look at O1 and O2. And as you can see, when this gentleman had his eyes closed, he has a very tight, sharp mound somewhere in the middle of the graph. That represents his alpha band. And it's at the first hashtag's 4 Hertz, then it goes by 2. So he's at 4, 6, 8, about 8.2 Hertz. So he has an 8.2 Hertz peak alpha. Now, I'm going to give you 3 examples. So what does that mean? Well, when you do a depression protocol for TMS, the standard stimulation is at 10 Hertz. So it would be actually 1 band faster than that, or 1 hashtag faster. But the average adult is thought to be around 10 hertz. This gentleman's about 8.2. Some people will ask me, well, what does that mean? Does it mean it's a sign of intelligence? Is it a sign? What I find is that it's not perfect, but it's a sign of your processing speed, meaning that the faster your alpha band is, what I've noticed, because we map everyone, is that a lot of the NFL athletes, a lot of the CEO and C-suites of these large tech companies, they're in the 11s. And so, but every once in a while, I'll see someone that's at 9 in that role. So, but in general, I feel that the faster your alpha band is, the quicker you seem to process things. In fact, someone whose alpha band is, that same band is skewed over to the right and is at 12 hertz, I feel like they finish my sentences. Or if an electrode's not working, they put their own hand on their head to adjust it. It's as if they're one step ahead. And I think sometimes it's good, but sometimes it can actually be not good, because I think it gets in the way when you're too many standard deviations variant from the population. So in any case, this gentleman has about an 8.2 hertz alpha band. I'm going to give you 3 examples, and you can choose whichever one you want to think about. If you're a football fan, think about your Tom Brady at 0102, and you step back into your end zone, and you want to throw that football all the way down to the other end zone. And the other end zone is FP1, FP2 on the top. Or you can think about a band. Think about the drum major. And you can think that when you close your eyes, the drum major at 0102 is starting the beat. And he's giving the marching band orders to march down the back of the head to the very front of the head. Or you can think about just simple as, I'm throwing a rock in a pond, and that pond happens to be your brain. And that rock lands at 0102. And then the waves that it emits just ripple through the brain. So basically what you want is, if your wiring is proper, meaning your hardware, and there's no chaotic lifestyle or you're otherwise at peace, you should see, ideally, the alpha band propagate from the back of the head to the front of the head. So what I like about this gentleman is, as you can see, you go from bottom to top, it looks almost identical. This gentleman has balance from the back of his head to the front of his head. It's balanced because, number one, it makes it to the top. Tom Brady's football makes it to from 0102 to FP1, FP2. And it makes it there, or the marching band, or the ripples, whatever you want to, but it makes it there without any attenuation, meaning that the height is exactly the same at the bottom as it is at the top. It makes it there without slowing down one bit. The football doesn't veer one way or the other. It's 10.2 or so, sorry, 8.2 at the bottom, and it's 8.2 at the top. It makes it there, so it's very balanced from top to bottom. What you also want in a brain map is balance from left to right. And as you can see, if no one's perfect, but if each line was a seesaw, FP1, FP2, FZ, F3, and the pivot was the alpha band, you could step back and say, for the most part, each line is balanced. I hope that makes sense. What I mean is that if each line, it wouldn't fall to one side or the other. So this brain map is balanced top to bottom and left to right. It's a very balanced brain. So that is what I think is near ideal. And it shows that it's pretty much comparable over 3 years. Now, let's go on to some that are not as perfect, or just some examples. Let's go here. This is a 9-year-old boy with ADHD. And there's a couple things I want to highlight on this brain map. This is all people with kind of simple pathology. A lot of times what we see in ADD or ADHD is the prefrontal cortex, which are the two electrodes recording from your forehead above your eyebrow, those seem to be less in signal than the others. And you can see that this boy from 0102 to the very top, he loses his signal a little bit at FP1 and FP2. And so when someone has less signal there, it oftentimes, manifests as inattention, distractibility, loss of focus. This boy actually underwent a lot of TMS, and I wanted to highlight a couple other things. You'll notice that, so it's not quite balanced up and down. It didn't make it all the way to the top. Also, if each line was a seesaw and the alpha band was where it pivoted, you would agree that it would tilt to the left, correct? I mean, each line is heavier on the left side. And what that means is that this child has a lot of neurons. So each line is representing 4 billion neurons. And just to remind everyone, for instance, in FP1, FP2, if you have less alpha, by definition, you have more delta, theta, beta, and gamma. So it all has to add up to 100%. So when you lose your alpha, it's made up elsewhere. And unfortunately, in this child's case, it was made up with a lot of delta and theta. And what that means is, essentially throughout his entire brain, at nearly every electrode, he has substantially greater neurons that are firing slow. He has neuronal slowing. This child also has sleep apnea, and he's undergoing MSC expansion at age 9. And for those who don't know, that's mid-face skeletal expansion, and it works great for someone at his age. But the point being is that, the neuronal slowing is likely from his sleep apnea. One thing I want you to walk away with and learn is that, we often think of traumatic brain injury as someone who's been in, maybe a war combat situation or a bad accident. But the reality is, anyone who's had a concussion basically has a traumatic brain injury. Anyone who's, I believe sleep apnea is a form of traumatic brain injury. The repetitive hypoxia, arousals, they stun the brain and cause neuronal slowing. So in any case, it's not just the football player, it's not just the war veteran. It could be people like you and I who may have sleep apnea that have neuronal slowing as a result from it. The other thing I wanted to show you on this boy's brain map is, you see the other band at about 4.5 hertz. It's a second band that rises from bottom to top. What's interesting is, we are doing the MSC on this child, and we are also stimulating them with TMS. So what TMS does is, what we generally do is we're trying to enhance the alpha band. But because we're enhancing the alpha band, we are actually, a brain that fires together, wires together. That's another thing I want you to walk away with. And what that means is that if the orchestra leader should be the alpha band at the back of your head, it should be Tom Brady throwing that football. But sometimes if you have a lot of neuronal slowing, if you have a lot of neuronal slowing from sleep apnea, sometimes the tail wags the dog. And what I mean by that is, as the football makes it from the back of the head to the front of the head, if there's substantial neuronal slowing, it starts to join the neurons that are slower, and you end up getting a leftward shift and a loss of the alpha. So in any case, what happened with this child is we stimulated to improve his alpha band, And as we're stimulating, what you'll see is that the beta and theta, the beta and gamma start to thin out, but so does the delta and theta. But it's interesting. It's almost like draining the ocean, and then you see the Titanic. This band at 4.5 hertz became more prominent as we treated him. So first we hardly noticed it, and then it started becoming more prominent. So then the question is, why does this child have a band? And what could cause a band? Well, any type of traumatic brain injury, such as a concussion, can cause a band. That could be a concussion band, or it could be a medication, like a hypnotic that he's taking. But he's not taking any medications. And the parents said that he never had a concussion. And he's had one previous surgery for tonsils and adenoids, but apparently there was no issue with that. But clearly something is there. And so we have him scheduled for an MRI. And unfortunately, we've been waiting still because of all the gear in his mouth. He can't get the MRI. And so we're waiting for the MSC to be completed before we see what happens. So the takeaways from this is the loss of height in FP1, FP2, the increased neuronal slowing throughout the leads, and this type of unknown explained band that he had. Let's go to another example. This is someone we just did recently. And so this is an executive and quite high functioning. And what it looks like is, it's a smeared, diffuse pattern. But look at it carefully. Once again, look at O1, O2. Do you see any type of band there? And if you look at the bottom, what you'll see is there's a small band at 4, 6, 8, 10, 12. Oh my gosh. This person's this is 13, about 12.5 hertz. That is one of the quickest, fastest processing brains that I've seen. So this is an executive with and makes sense where they're at, and they have a very, very fast alpha band. But unfortunately, it doesn't propagate down the head very well at all. And so this person is starting treatment soon. And what would they experience? Why are they here? Well, it's exactly what it says. It's brain fog. It's just a smeared, diffuse pattern. There's no synchronicity to the brain whatsoever. And they have a combination of fatigue, sleepiness, anxiety, loss of attention, focus. And then we'll keep going on. Go to the next one. So this is a grandmother, and she came in with reduced mental acuity. So she has a nice band, and you can see that. And her, we always look at the bottom, and her alpha band is 4, 6, 8, 10, about 9.2 hertz peak alpha. And what's nice about hers is, like I said, the alpha band, it propagates like a ripple in the water from the back of the head to the front of the head. It starts to propagate well. But right around the part where it gets to the middle of the head, you start seeing it diverging a little bit. And what you start seeing is a second band developing. It's almost like a 2.0 version of herself. And at some point, what you'll see is the second band is as prominent, and maybe even in some signals more prominent than the primary band. And what she'll experience from that is reduced mental acuity. We tested her for sleep apnea. She didn't think she had it, and it turned out to be severe. And so my thought of what happened was that you can see that it's higher. There's a lot more weight on the left side, and a brain that fires together, wires together. And so she had severe sleep apnea, which basically functioned as a traumatic brain injury. And the alpha band is trying to stay in its native form, but some populations of neurons are getting pulled to the left. And the further you are away from the source, the more likely it is to be impacted. If you throw a football and there's a little bit of wind, it's more likely to be diverted at the very end than it is at the beginning. But you can see even in her occipital lobe, where the alpha band emerges, that there's a long tail to it, to the left. It's getting pulled, but it's having its greatest effect furthest away from the source. Okay, so this is someone else we did recently. This is a Super Bowl MVP who's worried about chronic traumatic encephalopathy. And the sad thing is, I think he has it. And I mean, you can't diagnose it with this, but if you look at his alpha band, 4, 6, 8, 10, 10.3, I can tell you that he was probably faster than that at one point. He was probably in the 11 hertz range. Most of these top NFL players are usually in the 11 hertz range. So, and then you can see that even at the beginning, you can see a substantial amount of delta and theta activity in his O1 and O2 leads, the very bottom two for the brain. And as he tries to propagate the alpha band, you can see that he basically lost it. And the peak is actually here at about 4, 6, 8 hertz. So he has about a 2.2 hertz decrement and very diffuse and attenuated alpha band in his frontal leads. And there is no way this person would have won the Super Bowl with a brain like this. My guess is that in his prime, he probably had a clean alpha band that went all the way to the top, but due to repetitive hits, his alpha band was pulled to the left. These little peaks are meaningless. They overlie the EKG. So that's just EKG artifact. That's why we get the EKG. If we see something right above the EKG, it's probably not real. But this person, we are trying to get into the chair, but they're having a hard time processing that there may be something wrong, but that is to be continued. So this is an 8-year-old girl with sleep apnea. It actually happens to be the sister of the 9-year-old boy that I showed earlier. And so I did a sleep study on both of them. She also has a little bit of ADD, and you can see that her top 2 signals at FP1, FP2 are missing. Her alpha band is at 4, 6, 8, about 9 hertz. But what you'll note, what's interesting is I tested both of them. Her sleep apnea was moderate. His sleep apnea was mild. Look at how much neuronal slowing she has on the left side of the band. Look how heavy that signal is. I'm going to go back and show you his as a comparison, who was not as severe. I'm not sure if you can tell, but it's not as thick as hers. Hers is substantially thicker on the left. And I see this time and time again that for most people, the worse your sleep apnea is, the more neuronal slowing you have. And the more likely for most people it is to have an effect on the alpha band. Those are the 2 comparisons I just wanted to show you, the brother and sisters. Anyway, let's keep going. So this is she's a woman, and she came in with anxiety. And one of the things that you'll see with anxiety is that, remember I mentioned that the beta and gamma activity is elevated in intense concentration and problem solving. Well, the flip side is it can also be anxiety. And you can see that she's thicker on the right of the alpha band compared to the left. So there's a few things what I like about her brain map is that she does have an alpha band. It does propagate to the top. What I don't like about it is not very synchronous. It's not tight. And there's a lot of extra activity on the right. And that's exactly what she feels. Now, she only came in, she did not want to get her sleep tested. She just came in with anxiety. Actually, she was the mother of one of my patients. And then she just asked, can I do a brain map? And then she just wanted to go into treatment. She didn't want to focus on her sleep. Although, even though it's thicker on the right, it is thicker on the left as well. And I do want to get a sleep study on her, but this was just a week ago, so it's pretty new. This is a doctor who basically loved mountain climbing and fell off and hit his head. He doesn't take any medications or anything. You can see though that he has severe sleep apnea. Once again, he has an alpha band, 4, 6, 8, around 10 hertz. It fails to propagate, especially in the frontal lobe, it's absent. He has a secondary band at 4, 6, 7 hertz. That's most likely his concussion band. He also has a lot of neuronal slowing, and he is now attempting to use the Alaxo stents. I don't know what success he'll have with that, but he is going to try that. He's been having difficulty with CPAP, and he's a little too old to undergo surgery. But he is undergoing TMS. Okay. So this, I also wanted to show you this. This is someone we just saw this past week, and he's 96 years old. I said, what are you doing here? I got a little insomnia the past few years. And I want to show you it's not perfect, but he actually has a very attractive alpha band, 4, 6, 8. It's actually at 7.9 hertz. So his alpha band is in the theta range, which whenever I see something shift to the left, I do worry about slower processing, not necessarily dementia, but at least slower processing. But apart from that, he's straight as an arrow. And I believe the FP1 is just an artifact. If you have FP2 there substantially and FP1's missing, it's most likely just a bad signal that we had. But I just want to show you that it's not a function of age, meaning that it's not that it necessarily has to degrade. I've seen small kids with great FFT plots and small kids with awful FFT plots. And like, here's an example of a 96-year-old that, I mean, I think I would trade my own for his, with the exception of the alpha band speed. I think it looks reasonably good. Let's go on now to some treatments of what happens before and after and such. So this person is a very successful lawyer, has a huge practice, many, in a large building. He has ADD, he has anxiety, chronic pain, severe apnea, and multiple medications from Adderall, Xanax, Dayvigo, Effexor, other things. And so he came in and he did, and you can see his first brain map on the left before treatment. He had nothing. Only things that you see are artifacts from the heart on the very bottom emanating into the brain map. Apart from that, it's just smeared, diffuse, nothing. He stayed in a hotel for a month and he did 90 treatments. And he did about 4 to 6 a day, depending on the weekday. And anyway, total to get 90. And I want to show you what happened. The answer is nothing. After 45 treatments, the brain map did not change one bit. And we kept stimulating him. At 90 treatments, it didn't change one bit. What's fascinating though, after 90 treatments, he felt amazing. His focus got better. He was calmer. His tramadol, he reduced the dosage from 400 milligrams down to 50 milligrams. His apnea didn't change. It was untreated. He has severe sleep apnea. I personally think the reason why he's so, diffuse is just his untreated apnea for years. But he felt great. He had swagger. We had to essentially lift him into the chair with assistance when he first came. And then he was just walking out and doing great. So basically almost his pain, his movement, his focus, his and he reduced almost all of his medications. Almost everything was absent. And he left. But I wanted to show you that the brain map didn't change. That was about a year ago. And then he felt like the effects were wearing off. And one thing I wanted to tell you about TMS is that it is durable, in my opinion. And no TMS center will tell you this. But if you don't, my personal opinion is that something had to mess your brain up in the first place. Something had to desynchronize it. You can apply TMS and try to resynchronize it. Not that that's what anybody does, but that's what we do at least. But unless you stop, seek out, and treat the forces that are desynchronizing the brain, it may not be durable. So for instance, in this person, even though the map did not change, he felt fantastic. He came back for another 9 days to do 52 treatments. What was interesting, though, when he came back is we repeated the brain map when he came back to get a baseline. And I was so surprised that he actually had a small alpha band. And so what that tells me is sometimes the effects, potentially what it could tell us, is that potentially some of the effects, it's almost like an antidepressant. It can change the chemicals in your brain in a few hours, but the actual synaptic rearrangement and wiring it takes several weeks, 4 to 6 weeks. So perhaps that's what happened here, that he came back and he actually had an alpha band. Anyway, after his treatment, he maintained the alpha band. It was still there, and he felt well. He says that next time he comes, he'll come for 2 days, like a weekend, and try to cram as many as he can in to see if he can get by. But anyway, the reason why he came back is he felt like as if he needed it, like the effects of the treatment were wearing off. Okay, here we go. Let's go to the next person. So this is a gentleman who's the son of a highly successful tech person. And this gentleman came with reduced mental acuity. He has sleep apnea that's untreated. And if you look at and he came for TMS. And so once again, we obviously were doing the whole sleep workup. We're doing the imaging where he's, on the path for expansion and all that. But all that takes 2 years, and he wants relief now. And so so that's the beauty of TMS. It gives you immediate relief. And any case for many people. So if we look at his original brain map, we see that his alpha band is at 4, 6, 8, about 9.7 hertz or so. And it propagates reasonably well from bottom of the head to top of the head. But what's interesting is if you look a little bit to the right of that, you see a second band on O1, O2, 4, 6, 8, 10, 12, about 12.3 hertz. So then I asked this gentleman, hey, you have an alpha band at about 9.7. At some point in your life, did you feel that you were lightning quick, that you could process things like the Matrix? And he said, yeah, I used to be absolutely like genius level fast. And he said that he's nowhere near that anymore. And I said, well, either A, this is your actual band here at 9.7 hertz, or B, this was your actual band at 12 point something hertz. And because of your sleep apnea, you lost that band, and a second band has occurred and basically taken over. And so we talked about where to stimulate, and we decided to see if we can recreate that second band. And so we began stimulating in an effort to create that 12 hertz band. And what's interesting is after 7 treatments, that's what happened. No substantial changes, nothing big. It takes some time to modulate, and we always look at the bottom. But after 26 treatments, look what happened. His 12 hertz, actually it wasn't even 12 hertz, it's around 11 hertz now. That band is starting to create. Now, this original population is still there because it's wired there. It's going to take time to remove. But as he was going through the treatments, he felt an amazing improvement in his mental acuity. He felt like he was getting back to wherever he was when he was young. And so we stimulated him more, and we still stimulated, trying to create it. And what happened between 26 and 39 treatments is that you see it smudging. And that's exactly what happens when the neurons modulate. It's almost like an ocean. There's a peak, and then it troughs. Then there's the next peak, it troughs. Then there's a next peak. When they're shifting, we notice that the original peak will disappear and everything becomes mush before the final peak starts to emerge. And so at 39 treatments, everything started to smudge. But at 47 treatments, we're only seeing the faster hertz, 8, 10, 12. Now he lives in Phoenix. And so, he has to go back and forth. Unfortunately, his sleep apnea is, he has a very severely obstructed nose and an extremely narrow palate, and he needs a lot of work done. But he feels that once he stops the TMS, it seems to revert back after a couple weeks. And so, the ideal time, in my opinion, when someone has sleep apnea is either A, treat it concurrently, or B, after the treatments are done for the sleep apnea, because otherwise it just, you may regress potentially. Okay, let's go to the next one. So this is a lawyer with sleep apnea, and I just want to show you. Look at his original brain map. You can see that the alpha band is a little diffuse, but still relatively tight at 4, 6, 8. His peak is 8 to 9 hertz or so. And the brain map on the right is much tighter. You can see that the alpha band from the occipital all the way to the CZ electrode, to the middle of the head, has tightened up quite a bit. What do we do for this gentleman? All we did for him was CPAP. That second map is on 2 months on CPAP. And you can see how much more synchronized he became. So our plan with him now is he'll be seeing, we said, let's do CPAP for another 1 to 2 months. And let's see if the alpha band continues to sharpen and tighten in the frontal leads. You can see that at the very top, it hasn't changed very much. And so if it does change, then we're good. If it doesn't change, he wants to try the TMS to, basically have a stronger guiding signal for the alpha band to propagate. This is a therapist who basically, it's been a long time, but anyway, she has a very poor diffuse alpha band on her original brain map at 4, 6, 8, 10, 12, 11.3 hertz. So incredibly bright person, or at least quick, but suffering, anxiety, depressed, fatigue, sleepiness. And so she did not want to do TMS right away. So she wanted to do CPAP. Some people like to do in staggered ways, and she has surgical things pending. But you can see that just after 3 weeks on CPAP, she starts to emerge a little bit of alpha from the posterior to anterior part of her head. And then after 6 weeks, it's a bit better. And after 26 weeks, it's about the same. So what I will say is that when you have a traumatic, I'm calling sleep apnea a traumatic brain injury now, but when you have a traumatic brain injury, whether it's playing football, a concussion, or sleep apnea, your brain will, rewire. And when you remove that offending agent, it may come back, but it doesn't usually come back all the way. It's almost like you can't put Humpty Dumpty back on the wall as they were originally. And so I think that's why, even if you do a nasal surgery, expansion, advancement, CPAP, whatever, you're left with some residual symptoms. And I think that's where I think the TMS is helpful. And then this is a gentleman. I just want to tell you that what's hard for me to tell is if someone will neuromodulate. In my experience, about 80% of people modulate pretty well. But time is unknown. Like, I could walk into a room and say, okay, I'm the band leader, everyone listen. And some different brains come to attention quicker, and different brains come to attention a little bit slower. So this gentleman, on his first treatment, on his first brain map, looked like a mess. It was nothing, smear diffuse. The person owns 7 companies, is anxious, has sleep apnea, but didn't want to do anything really, just wanted to do the TMS. And so after 11 treatments, and I told this gentleman, you may need months in that chair. You're not giving me anything. The machine's gonna have to do all the work, and you're not treating anything. Anyway, it was remarkable, because normally it would take 40 to 60 treatments, but after just 11 treatments, he started to develop this alpha band. It started to emerge, and you always see it at the source first, because that's where it starts. And then after 16 treatments, he started to create that alpha band all the way from the bottom to the top. Now, it's not the best alpha band, but it's an alpha band. And then he actually felt so well after just 16 treatments that he went to once a week. And I was just shocked, because that was probably the quickest result we've seen. And then he's been doing once a month, and this last one was done probably a month or 2 ago, right? But he's maintained it, and it doesn't go away. So he comes once a week. Actually, the last 2 weeks he hasn't come. I think he's done completely now. So some people respond early, and I cannot tell you why some do and some don't. This person is an administrator of a very large healthcare organization. It has severe sleep apnea, but is 100% compliant on CPAP. Okay, so you can't blame the sleep apnea anymore on this person. And they came for reduced mental acuity, anxiety, some depressed mood, apathy, and a baseline. Once again, here though, I would call it a smeared pattern, but you could potentially see a drawn out alpha band. But I don't think so, but maybe. But if there's an alpha band there, it is so diffuse, it's hard to tell. After 10 treatments, nothing happened. She was very discouraged. And I said, it takes time. Give us some time. Give it at least 20 treatments. And if you don't see any changes in 20 treatments and you don't feel any different, then we can, because a lot of times the brain map may change before the person feels anything. Just like you take an antidepressant, it changes the chemicals, but you may not feel any different for weeks. But after 20 treatments, she started developing a more substantial alpha band. And it's actually starting to propagate up to her upper head. Unfortunately, her alpha band is at 4, 6, 8, about 10 hertz in the back of her head. But by the time it gets to the front, her alpha band is at 4, 6, 8, 8.5. So she has almost a 2 hertz slowing. And then she did 30 treatments. And what's nice is that the alpha band is propagating still. It is still better. And then she took a lot of time off. She went to Europe. She did her, whatnot, right? And she came back after a month. And what we noticed is that the only thing I'm showing you here is that it maintained. She did nothing, and at least it stayed the same, but she's still coming to us. The goal that she would like to do is to have her, well, still, she's been feeling better and she feels better, otherwise she wouldn't come back, but she wants to see if we can reestablish this 4, 6, 8, 10, 11, 12 hertz alpha band all the way to the top, because this is still a little bit slower than where it starts with. Let me go to the next person here. This is he was a senior engineer at one of these tech companies here. I guess entrepreneur is not correct, but he has apnea, he's on CPAP, and he's very, he's like an engineer. He wants to do everything one thing at a time. So the first brain map on the left was his baseline. And then he went on CPAP for 3 months, 3 or 4 months. And he did beautifully on CPAP. He was able to wear it every night, not the first month, but after the first month, he's able to wear it. And then he said, okay, I said, let's repeat your brain map when you come back. So the second brain map is him on 3 to 4 months of CPAP. And as you can see, it didn't change much. It didn't do much at all, actually. And he felt a little better on CPAP, but not substantially better. And his brain map didn't change that much. So he decided to go ahead and try the TMS. And then we stimulated him. And you can see that we're creating this alpha band just after 10 sessions. And he felt, once again, he's a quick responder. He started feeling better. He wasn't sure at this time. He's been doing it now a little bit longer and he feels better, but he is recreating this band. And what we're hoping now is that this secondary band will 100% disappear and all the neurons will start to fire in synchrony at the higher rate. So here's an example where CPAP did not seem to help, but TMS did. And pretty much every variation you can come up with, if you ask a question, can probably happen. Anyway, I just wanted to say my website is sleepandbrain.com. This is all data that I'm collecting right now. We run a brain map on everyone before surgery, after surgery, before CPAP, after CPAP, before TMS, after TMS, sometimes just time alone. But if anyone, I just wanted to just say this, that if anyone is ever listening to this talk, and if they say the word blue monkey to me, and if they ever come see me, I'm happy to give them a substantial discount. Just remember the word blue monkey. But anyway, I wanted to now go, that was the end of my talk. Did anyone have any questions? I see, have you seen how our TMS results compare to FFT brain map changes with other therapies, ketamine, psychedelics, electroshock? The answer is not yet. So once again, I do it on every single person, and I do it as a follow-up on every follow-up visit that a patient has with me. They get a repeat brain map. We just track them. And I have not seen anyone pre and post ketamine yet. And the psilocybin therapy, I have not seen that yet either. And I don't have any patients that have undergone ECT. But I've done a lot with CPAP, and I've done pre and post nasal surgery, and I see an improvement. I've done pre and post E's, at least one patient, and they had improvement. And so it's still early. I think the SAINT protocol, the one thing that the SAINT protocol taught us here is that we were originally only doing 1 or a maximum of 2 TMS sessions per day. That's all we were doing, because we were under the belief that doing more than that was too much. But the SAINT protocol did 10 sessions per day. And when you listen to the discussions by the primary investigators, the principal investigators, they said that the refractory period for the brain is about 50 minutes between stimulations. So after the same protocol came out, some of our clients that fly in from out of the state and whatnot, we started offering up to 9 or 10 sessions per day if they wanted to. We reduced the rate, and then we just would do several. And what I found, we were a little nervous at first, but what I found is it seems to work. It seems to work if you do it once a day. It seems to work if you do it twice a day. It seems to work if you do it 3 times a day. It seems to work if you do it twice a day, 3 times a week. But I will say that my preference is that I believe it's like going to the gym. You can exercise 10 times a day, and you can do it for 5 days, but it's probably better to go to the gym once or twice a day over 25 days. And so I do think that, in my personal opinion, that there's more durability the longer you can stretch out the time. If you wanted to learn more about TMS, there's a TMS Society. But like I said, TMS is only approved for 3 things: major depression, recurrent, obsessive compulsive disorder, and smoking cessation. Everything else is off-label. I do the on-label treatments, but the majority of my patients are off-label. In thinking of sleep apnea as a chronic stressor, you'll often see individuals enter a chronic pathological steady state in which the sympathetic nervous system is dominant, and my feel is that state persists beyond surgical management. Wondering if TMS has an effect on regulating our stress response system, or ideally returning it to a healthy steady state. TMS, when you stimulate neurons, what you're doing is you're upregulating the number of vesicles that are at the nerve ending, and you're also upregulating the number of receptors on the other side of the other nerve that it attaches to. And so you're really beefing up your entire system. And I've seen data that TMS can improve lymphatic clearance in animals. I've seen data that TMS can improve respirations. In my opinion, I think just stimulating the brain and beefing it up and bulking it up just makes almost every aspect better. I think it's not, I can't prove it, but I would think that high sympathetic tone does degrade the body to some degree. And once again, I'm calling it desynchronization, but no one's looking at this. That's the problem. It's not really looking at it. Right now, most of the academic world is trying to find one spot that they can inflict heavy, high-intensity TMS on to treat, but no one's looking at the whole personalization. It's just starting to emerge. Thoughts on how permanent neuronal injury is and the mechanism of TMS, seeing as how CNS neurons cannot regenerate. I have a different attitude now that I've been doing this. I used to think that the older you get, the less you can modulate. But I've seen small children that don't modulate well at all. Like those 2 kids I showed you earlier. They did not do well with TMS. They did not do well. Nothing bad happened, but they did not modulate well. But then I have 80-year-olds that modulate beautifully. And so I don't think it's a function of age. I think neurons can modulate no matter how old you are. I don't know if there's a genetic predisposition for some people to not modulate. I don't understand why there's a subset of people that for some reason I stimulate and nothing seems to happen. But for the majority it does. I would say 80 to 90%. But yeah, it's unknown. But I do think that more neuronal injury is reversible than we think, just based on what I'm seeing. Familiar at all with Dr. Robert Nouveau at UCSD's danger response theory, in which chronic stress brings about a hypometabolic or even hibernative state? Yeah, I mean, I am not familiar with his work, but I do think that the body is not designed to be in a chronic state of stress. And I think first it leads to anxiety, and later it leads to depression. And that's just the behavioral side that we see. And we don't even see the other neuronal injuries. And so it is a bit sad. And that's why I always ask people if they're anxious and depressed, which came first? Do you have any ideas for things that can improve response time to TMS, things that can aid the brain's rewiring process? Once again, we're the only ones, we basically go through your history and we try to find anything that you could be doing to desynchronize your brain. Smoking pot, various medications, just different things. And our whole goal is that we want to not only resynchronize your brain, we want to stop the things from desynchronizing your brain. And I think the combination as well. And the fascinating thing is that we're also focused on sleep, 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 and breathing and breathing and breathing. And we forget that in the very end, it's all processed in the brain. It amazes me to see people with a recessed jaw, narrow arch, nasal obstruction, not do anything but TMS, and they feel better. And it's very surprising to see that, because the way we were, we're all in this together in this group, that we would think that we need to surgically fix everything to get to that ideal state. The reality is we can get to it potentially without doing anything, but it may not be durable. How do we determine which frequency to stimulate at, and where and how deep to stimulate? That's so we have our own program. I don't want to go into the details of that, but we repeat the brain map, as you can tell, every certain number of sessions on TMS, and then we change the protocol. It's an escalating protocol. It varies from site to site, and it's just a program we have that does it. Yeah. So, but yeah, your point's valid. Each person has their own specific protocol. Do you find that stimulants are often neurotoxic or counterproductive overall? Well, no. I think if when your brain is imbalanced, your lifestyle is imbalanced. And what I mean by that is that when you have an imbalanced brain, you need an imbalanced lifestyle to match it. So a lot of times, I get sent patients on pot, stimulants, antidepressants, this and that, and they'll ask me, should I stop all these? I say, no, you need all these things. That's why you're on them, right? But what I'm hoping is that once we fix their sleep and other things, and we resynchronize their brain, that once we resynchronize the brain, you're just not going to want to drink as much. You're just not going to want to take take as much antidepressant or as much pain medicines, and it'll naturally start to wean off. And we see that time and time again. We've had at least 2 people that have been on pot for 20 plus years that have come off of it, or at least they're down to once a week now, more behavioral than anything else. Following up on R's questions, thoughts on antidepressants, GABA, benzo? Oh, yes. If you take a lot of benzos and whatnot, you'll see a slow band. You'll see actually almost like the equivalent of a concussion band on the FFT plot. So those are all things we look for. And I know I'm a neurologist doing TMS, but I don't understand how you can really do TMS and not be a sleep specialist and not look for other etiologies of what's desynchronizing the brain. Can conventional TMS be detrimental, stimulating at the wrong frequency? That is a fantastic question. So if your primary alpha band is at 11.5 hertz, and the FDA protocol for depression is at 10 hertz, I don't know. I've had a few patients come to me for the FDA protocol for depression, and I'll tell them, look, we can do it, but I worry that I'm stimulating you at a rate lower than what your brain is at. And I also tell them that we could just change the frequency, but then it's no longer on label. And so it's a decision. I just try to lay it out, and I don't have any data that it's bad. But in my opinion, I don't, anything over 5 hertz is stimulating. Anything under 5 hertz is suppresses the brain. I don't know why everyone wouldn't want to run a brain map, find out their primary peak alpha band in the occipital lobe, and at least stimulate at that frequency for depression. But I don't have any data that makes sense. It just makes intuitive sense to me, but I don't have any data that that would make a difference, or maybe it would cause a worse outcome. It's unknown. How long have you been using TMS for? How durable are the outcomes? So I've been working with a group for about 2 years before this, and then I've been doing it here in my private practice. November 3rd will be 1 year. And so what you'll find is about, that other group does about 85 people a day. What you'll find is about 30% of the people seem to come back. And that's with us trying to find, treat the sleep apnea, treat everything else, get people off their meds and other things. So yeah, about 70% don't need it. I'll just be open. I'm very transparent if anyone knows me. I treat myself, and I've probably done probably 200 to 300 sessions on myself by now. And I think it's great, and I enjoy it. And to me, I do it once a week, and it gives me the ability to, give the attention the patients need and the time they need, and work long hours. Do you think the nature of TMS could be recreated to a lesser extent through specific daily exercise, meditation? Yes, I do think so. The two primordial aspects of an organism, are breathing, are respiration and digestion. So I think if you breathe well, which we're all, I'm sure anyone on this call is probably very knowledgeable about, and we have good digestion, meaning your diet and everything is very clean, I think that'll go a long way to keeping you healthy and having a nice alpha band. I also think that like when you meditate, you're basically creating alpha. When you're keeping your eyes closed, your thoughts clear, and you're awake, you're basically trying to stimulate alpha. The problem is, not like, I'm awful at meditating. I find it quite boring. There are people who can do it for hours, but in my opinion, the method we're doing is almost forced meditation. Just close your eyes and put 4, 5, 6,000 meditation impulses in your brain. Have you seen any connection between brain mappings and psychological interventions, talk therapy, career change, improving relationships? I do have a couple patients with psychosis, and I'll say that when their psychosis is active, their alpha band looks very poor. So there's two things. I'm just talking as I'm thinking of things, but there's two things that promote a nice alpha band. You need the hardware. The hardware meaning the wiring has to be intact. All the networks have to be intact. You want to propagate that alpha band from occipital or frontal, the wiring has to be intact. The second thing is software. You can't do psychotherapy in a household that has screaming and yelling and people throwing things and punching each other. You need to have a calm. You can't do TMS when someone is actively having a panic attack. So in other words, there's two things that propagate that alpha is the hardware has to be intact. And if not, we have to somehow create it. Or B, you have to be in a non-panicked, calm state that allows the intervention to work. Yeah, I've invited Dr. Lee to come sit in the chair, but Dr. Lee is very, he doesn't, anyone that knows Dr. Lee knows that he's very curt, very brilliant, but very curt, stays with the plumbing of the airway, and that's it. But I did ask Dr. Lee if he'd like to do 10 patients pre-ease and 10 patients post-ease for FFT plots to see if there's an improvement. And he did seem interested, but Dr. Lee is very busy, but I do think it would be nice to add a cognitive functional improvement aspect to his method for his procedure, the ease. And I would love to map Dr. Lee's brain to see what it looks like. But any case, that's the interesting thing I'll say. When you do this, the people you have dinner with, every patient that walks in, every single person, I'm always curious what their brain map looks like. It has not gotten old, because you never know. When you can talk to 10 people and they all seem fine, but you can tell from their brain map who's suffering. And I find that interesting.